I wanted to follow a bit on from David, and I'm really fortunate to be able to speak after such a fantastic speaker, thinking a bit more about testing and how we could perhaps consider an evidence-based approach to testing. So as Adam kindly said already, one of my day jobs is very much teaching and directing this master's program, but in terms of teaching, one of the things I teach is diagnostic studies, and I sort of talk to students a lot about thinking about evidence for diagnostics, how might we consider that, and what sort of questions should we be asking. And this is a real photo of me about a few weeks ago doing exactly that. That's not AI generated, that's the real thing. So one of the first things I often ask students to do is to start off with, we always have to start with what is the question? What question do we have when we're thinking about evidence for a test? And in terms of that, we want to think about who are the patients or the population that we are considering in terms of the testing. What test are we interested in, that index test, and what are we comparing that to, so the reference test, and what are we trying to diagnose? So really just formulating that very clearly and being clear on what it is that we're trying to do. And then some of the questions I encourage them to think about are things like, so who are the patients? What's the spectrum of patients that we're interested in? And is that appropriate if we're looking at some evidence? What setting is testing happening in? Where and who are we testing? What reference test are we using? What's that? And is that appropriate? And are we actually thinking about the clinically important outcomes as well? So then when we're thinking about the testing that happened in the pandemic, or we're thinking about pandemic testing, we want to ask all of those questions as well. We want to think about were we interested in symptomatic people, asymptomatic people? What setting were we testing in? And what tests were we interested in, the PCR tests or these lateral flow tests? And if we think about what actually happened in the pandemic in terms of settings of testing, so certainly there was testing in hospitals, in sort of clinical settings, but also testing at home, people testing themselves at home and testing in all sorts of other areas, things like airport testing centres. I think most of us remember having to go through those potentially, supermarkets, even football stadiums, all sorts of places where testing was happening. And then in terms of the kinds of people we were testing, certainly symptomatic, so people with symptoms or signs were being asked to test themselves. But there was also asymptomatic testing going on. So people were being asked to do tests for all sorts of reasons, being able to go to work, being able to go and visit somebody, to travel, to go to a restaurant, all sorts of reasons, and in both different settings, and then symptomatic and asymptomatic testing. So if we think about those lateral flow tests that we were all being given or we were asked to use, and we then think about, well, what was some of the evidence underpinning any of that? So this is a systematic review that was first published in August of 2020, where they looked at those rapid point-of-care tests, and they looked at the accuracy. At that time, they had found 22 studies that assessed that, 22 included studies, and they found that none of those studies were at low risk of bias. And this is the sort of main finding from that systematic review, which says that the evidence had limited applicability. There's a lot of uncertainty whether these tests will actually perform in this way in practice as well. And then also, according to the symptoms, the duration of symptoms, and in asymptomatic people. Now, take note, that was August 2020. And I think we all remember how much testing had already been happening. And if we think then that was the level of evidence at that time. That systematic review has since been updated, and the most recent version was put out in July 2022. And then at that stage, they found 152 studies, so lots more evidence, so that seems like a really good thing. Except if you look at their findings then, although there was a lot more evidence, there was still this lack of considering the clinical performance, the lack of well-designed prospective studies and also comparative studies, and particularly also thinking about the clinical setting, asymptomatic and symptomatic testing. There's also a lack of reporting of symptoms, symptom duration, and interestingly, all of those 152 studies used PCR, so some sort of nucleic acid amplification, mostly PCR, as their reference test. if we then think about the volume of testing that was going on, so this is just a snapshot. This is work that was done by my colleagues Carl Hennigan and Tom Jefferson, where they just took some data from Worldometer and looked at the number of tests per million and the number of cases per million in different countries. And here the sort of bubble size represents the size of the country, and just looked at how those correlate. And you can see, first of all, there's a lot of variation going on. And if we look a little bit at what's happened for us in the UK, for example, you can see there was a lot of testing going on, as much as perhaps in countries like Austria or Denmark, but we were detecting fewer cases. And I think if you look again at the amount of testing that was going on, and then you think about, if I can just refer to the UK, that the cost of this as well was equivalent to about 2 years of the GP budget. So 2 years of the budget for general practice is as much as was spent on this sort of testing. And then if we think about what any impact of that testing, what did that actually do in terms of anything that might have changed or changed the course of things, I think we have to really start to think about what evidence was underpinning any of this. And then if we sort of reflect a bit more on that reference test, which they were using PCR, but yes, thinking about, how was that appropriate in terms of thinking about clinical decision-making, thinking about policy decision-making. And there we did this systematic review on looking at viral cultures and correlating that with PCR and also the clinical course. So David has already very eloquently talked about a lot of these issues. So in this systematic review that we did at that time, we had shown there as well that this data has this relationship between the time of onset from symptoms to the timing of the specimen test, clearly that cycle threshold, and symptom severity, as David highlighted. And in that review, we found 12 studies that showed that CT was significantly lower when you have that the live virus culture, and then 2 studies reporting the odds of live virus culture being reduced by about 33% per unit of CT. So very much the sort of work that David was doing as well. And just to show you those 2 studies we found for that, there's that relationship, as we've already seen. So as that CT goes up, you have less chance of having live virus. And then in terms of the time course, about day 3 is where the best chance of having the detecting virus, and then that reduces over time, and that CT value goes up. So that's, of course, for healthy people, and as David already said, if you have any immunocompromised patients, we did the systematic review on transplant patients, looking at viral culture and CT correlation. You can see that can go on for much longer. But clearly it's important to consider at what CT are we actually using these PCR data. And then how much did we actually know about any of this? Is this all suddenly new and we've got no idea that this was going on? So this is actually a piece that was put out by Public Health England in October 2020, kind of highlighting this for decision makers, to this understanding of that cycle threshold and the RT-PCR. And they had this I found very helpful graph in that document showing exactly this, exactly as David also showed. You have that increase at the early stage of infection, but then you have that very long tail of potentially having a positive test still, but how that correlates to any infectivity. So that was there, and it was clear, and they clearly said in this document as well, sort of single PCR values or results shouldn't be used for clinical decision making. You should also have the context of the clinical picture and take everything into account. But somehow a lot of that just went out the window, and we were just using PCR positive, yes, you have the virus, and that's that. So Carl and Tom also had a look then at what was going on in terms of the PCR testing in the UK, and making some freedom of information requests to understand sort of the PCR testing that was going on, and highlighted it in this report. I think the first key interesting finding is that they weren't even sure how many different PCR tests were being used. And the best information they could get from Public Health England was probably about 80 or 85. Across Europe, it could be as many as over 400 different CE mark tests that were available. Only 2 provided answers on CT values and said that sort of at a set time, about 24 to 38% were over 30. And then in terms of a cycle threshold, it said that in most of those that did respond that had the CT value for a positive result varied from 30 to 45. Now, because I have been so fortunate that David was speaking before me, think back to what he just said, and then you look at that, and this is what was being used in practice. So that report also concluded that we have this current system that really requires changes to ensure that it's offering accurate diagnostic data and data that we can sort of trust in terms of thinking about decision-making. Clearly, PCR is a really important and powerful tool, but if we are not using it in an evidence-based way, then we really risk undermining its usefulness and also its credibility. So then another piece of work that we did was then thinking about sort of developing a hierarchical framework for assessing transmission and the causality of respiratory viruses. And this is where we looked at a series of systematic reviews that we did of over 591 primary studies of transmission across the different modes of transmission. And we were looking at the methodologies, the shortcomings, heterogeneity in the design, the conduct, and the testing, importantly, as well. So there you could see we were looking at, in terms of what was being reported, in terms of how the testing was done to look at that transmission, whether they just reported binary PCR, whether CT was reported, and then whether there was a consideration of infectiousness or infectivity, looking at whether the CT was lower, viral culture, cytopathic effect, genome sequencing, or even serial viral culture. So you can see here that the vast majority of the studies we found across all of those modes of transmission were reporting binary PCR results. And as you go across the table, you can see very, very few actually considering those other measures that David and his colleagues were looking at to see actually thinking about infectivity and infectiousness. So based on that, we developed this hierarchy of evidence to sort of inform this, and with the binary PCR being, let's say, the bottom of the evidence pyramid in terms of being able to inform microbiological and clinical aspects, and then perhaps at the top of the pyramid, maybe serial viral culture or decreasing cycle threshold to make those clinical decisions. So can we have an evidence-based approach to testing? Are there some things we could think about? I think the very first thing I'd want to say is that we should recognize that actually evidence for testing is as important as evidence for treatment. We may consider perhaps a repository of tests or a strategy to evaluate tests more rapidly. So yesterday we heard very, very eloquently about how phenomenal the intervention setup was. You know, you had platforms and trials that could be run very rapidly for interventions. And we've heard that for non-pharmacological intervention, that's been less so, and also for diagnostics. Where was all of that? You know, lots of tests being developed, and what was the level of evidence there? We would need evidence in the setting. And we also want to think about what is the appropriate outcome of interest. So we're not interested in finding pieces of RNA, as David said as well. What we're interested in is transmission and infectivity. So going back to when I talk to my students about evidence, we always consider that what we want to do when we want to understand a problem, we want to understand it from a range of perspectives. And we want to always focus on evidence and also thinking about how we use and interpret data. I think it's always important that we go back to the source of any claim, that we think about where that came from, that we critically appraise that evidence that we do have, consider the outcome, the levels of evidence, any biases and how those might impact that evidence, and also importantly, understand the limitations. So if we are using PCR, for example, what's the limitations of that? How does that actually help us? And then particularly in relation to important outcomes to patients and also those clinical outcomes. And of course, integrating evidence with experience, expertise, and available resources. And all of that is not only in interventions, this also applies to testing. And I think most importantly, I think we would always ask that if the evidence isn't high quality, as it wasn't in terms of testing, then we should ask why we are not improving the quality of that research. Thanks very much.